Thank you very much. It's a pleasure for us to be here. We had the chance to collaborate with South America for a while now, and mainly with Montevideo, but we also participated to other activities with South America and office and PAO. So it's certainly an honor for us to be here. We were not at the Tulsa conference. However, I realize that many of the ideas that we will share with you today are related to what was discussed in Tulsa. So I will make the presentation, and Martin, who is the co-coordinator of our collaborating center, will complete the presentation. Let's talk a little bit about Canada Healthcare Organization and the healthcare system. First, it's a universal and public system. It is relatively free, except it's paid by our income taxes, okay? But people don't have to pay for their care. It's a integrated and complementary, very much emphasis on the integration and complementarity of levels of care with primary, secondary, and tertiary levels, and a lot of efforts to make sure that there is integration. It's health and social services. It's not only the Ministry of Health, it's Ministry of Health and Social Services integrated together. And there's a major role for primary healthcare physicians and family physicians and broad-based specialists in the healthcare system in Canada and Quebec. Just to say a few words, Quebec is one of the 10 provinces in Canada. Our country is 33 million people. Quebec is 8 million people, and it's the center of the country. In Quebec, since 2002, we have introduced what we call family medicine groups, GMF, or Groupe de Médecins de Famille. And it's, in fact, actually it regroups at least five family physicians and other professionals, nurses, social workers, psychologists, ergotherapists, and others. A list of registered patients for that group, a wide variety of services and on-call systems, okay? And you will, Martin will discuss to you about what is the practice of family physicians in Quebec. And you will see that they do a lot of activities, including pediatrics and obstetrics and gynecology and hospital care and so on. And various and mixed remuneration systems and rigorous evaluation. Let's talk about social commitment and change process. Development and implementation of primary health care is complex. Reynaldo Older talked to us about values, principles, elements. And many people talk about partners, governments, health organizations, society, population, health professionals, and academic institutions. Each partner must play its role, and each partner is not more important than the other, but all of them must play their role. Faculty of medicines are one of these partners, and they must do their work. And as one of the speakers told us this morning, faculties of medicine can be the engine of change. I think that this citation is very important for me when we talk about primary health care education and how important it is to start education with a focus on primary health care and family medicine and all issues about primary health care if we want our graduates to embrace the primary health care in their future career. So for me, as Platon said, the direction in which the education starts a man will determine its future mind. So we should keep it that about when we talk about medical education and undergraduate medical education program. United States, Canada, Quebec, okay, Quebec, and Sherbrooke. Sherbrooke is a city of about 150,000 people, approximately 150 kilometers east of Montreal, which is the biggest city in our province. Okay. There are 4 faculties of medicine in Quebec, 17 in Canada. All of them are, I would say, government supported with fees. Okay, all students must pay fees. Actually, in Quebec, in our province, the fees are relatively low, and in fact, approximately 25% of the fees, the main fees that are paid in the other schools in Canada. In the 60s, at the end of the 60s, 4 medical schools were created in Canada. So there was one in McMaster. You might have heard about McMaster, Calgary, Newfoundland, and Sherbrooke. And recently we had a new one, and Roger will talk about the Northern Ontario School of Medicine, which has been the newest medical school in Canada. This is Sherbrooke Faculty of Medicine and Health Sciences. You see that we have a nice country. Okay, so there is the University Hospital at your left, the Research Center and Medical Education and Nursing Education and Rehabilitation Education buildings on the right. Okay. Sherbrooke was founded in the 60s to respond to the needs of community out of large cities. This is clearly stated in the foundation objectives. It's recognized for its educational innovations for many years, and since 2001 it is a WHO PAHO Collaborating Center. In 2006, it officially changed its name to become Faculty of Medicine and Health Sciences, considering the fact that we also train nurses, rehabilitation professionals, and other different group of professionals. This is the number of full-time teachers and part-time teachers and employees and students in our schools, actually. Sherbrooke has been socially committed to primary health care also since its beginning of activities. Okay. And in fact, it's interesting to realize that its mission and its 4-year strategic plans include the term social responsibility, a term that we have alluded this morning about social accountability. And in fact, in our plan, in our mission, social accountability is part of it for more than almost 15 years, actually. And we discussed this morning about the fact that Flexner influenced medical schools education in the beginning of the past century. We may certainly think that actually social accountability is becoming more and more the criteria on which we will evaluate medical schools and their role. Okay. Our mission. So the other thing is the family medicine residency program has been there for more than 40 years, and Martin will talk to you about this, in community-based sites. Our school is committed to train family physicians and broad-based specialists or specialists, generalist specialties, and we have also international collaboration. Recently, I was at a meeting at the Northern Ontario School of Medicine where we discussed innovation in medical education. And we were a bunch of schools, most of them less than 15 years old. I don't know if Sherbrooke is an old school, which is 45 years old, but one thing is sure, even though it might be old in age, it is still young in its mind. Training physicians in Canada, that's the model. Okay, people go to primary school, secondary school, and they go to a college, general college, to come in the MD program. Some of them will also complete university degree before coming in the MD program, which is 4 years. There's only 2 schools, it's 5 years in Canada, so it's 4 years. You can either go to family medicine, which is an integrated program, but 2 year long, or a specialty program in the different specialties, and then for 5 to 7 years, and you go to practice. So we received our first students, and our program was already system-based and with a basic and clinical science integrated curriculum. In 1987, we made a major curricular reform with small groups, problem-based learning, community-oriented education, refocused our content. In the last 10 years, we significantly increased the number of our first-year students due to the needs of the population, and we also, at that time, introduced pipelines for people in regional and remote areas, pipelines for indigenous people, pipelines also. We have a commitment for Francophone minority communities in Canada. And in fact, there are Francophone minority communities in all provinces, and we are committed to support them, and we have a pipeline for these people. We also introduced the MMI, maybe you have heard about multiple interview in our admission process, where we measure non-cognitive aspects. In 2006, we implemented 2 outside campuses, and I'll talk to you later about this. And actually, we are in a process of reviewing our curriculum with hope to have a new integrated, I would say an improved curriculum in 2 years from now. Mainly small groups, mainly problem-based. 2 sites. So Sherbrooke, we opened a site on your left, which is a regional it's a rural or a remote region in Quebec, 500 kilometers from Sherbrooke. And then in the neighbor province with New Brunswick, it's a bilingual province, okay, with no medical school. And then in 2006, we opened a campus. We now offer the whole medical program in these sites. The objective of this was to better respond to the needs of people coming from regions in Quebec, and also to better respond to the needs of the people from New Brunswick. In 2006, we also went through a major clerkship reform and general competencies. CanMed's role, maybe you have heard about CanMed's role, so, medical regular competencies, but also communication, utilization of resources, working with team, professionalism, and also. And we have a task-based program now, which is based on 100 most relevant, and I would say transdisciplinary, not specialty-based, clinical situations, like abdominal pain, fever, or something like this, for which appropriate differential diagnosis for a general physician are outlined. Expected tasks to be completed by graduates are delineated, and levels of competencies defined. Let's talk rapidly about learning opportunities for primary health care. And I will just rapidly present our curriculum, which is a 4-year curriculum, 2.5 years, mainly what we call preclinical, even though there's a lot of clinical activities, and 1.5 years of clerkship. It's an integrated curriculum based on systems, okay? And we have 2 transversal program, which are clinical skills and learning of all the communication clinical skills, and also the other one is professionalism. So I will let Martin to talk about what we do.
Hablamos del currículum en la atención primaria de salud. En los 2 primeros años, los estudiantes van a hacer una pasantía de inmersión clínica en la comunidad, en pequeñas oficinas de médicos o en pequeños hospitales. También lo hacen en el segundo año. Lo que no está inscrito aquí es que también necesitan que seguir durante 2 años y medio, como el preclínico, necesitan que seguir un niño de buena salud durante todo como de 2 años, y también una persona de edad. Les hace ver lo que es la normalidad del funcionamiento de un adulto y de las personas mayores. Para aumentar lo que pensamos es que para aumentar la posibilidad de trabajar en el medio en la atención primaria de salud, tenemos muchos profesores. Trabajamos en pequeño grupo y entonces tenemos muchos tutores, y de estos tutores hay como más o menos 25% que están médicos de familias. Quiere decir que como algunos hacen la ginecología, la pediatría, la unidad de cardiología, hay médicos de familias que hacen la enseñanza, son tutores de estas fases de enseñanza. Y también hay más o menos 25% que son especialistas generalistas, como medicina interna, pediatra, y también los ginecólogos. Los médicos de familias también tienen una implicación en el programa, como director de programa, director de unidad, de fases, también están en el comité de promoción y de evaluación, y hay también el director del externado, que es un médico de familia. En el externado hay 64 semanas, 64 rotaciones. Rotaciones son de 4 semanas. En estas rotaciones hay 8 en medicina familiar, 20 en especialidades generales, 4 en salud pública. Y también hay pasantías electivos que llamamos, que eligen los estudiantes, y más o menos la mayoría toman al menos 4 semanas de atención primaria. ¿Dónde hacemos la formación? Es una formación que está integrada. Hay un hospital universitario que han visto la foto, okay, el CHU, que está en Sherbrooke. Sherbrooke tiene más o menos 150.000 de población, pero toda la región está a más de 325.000. Y cada hospital universitario tiene como una red, y esta red está de más o menos 1 millón de población. Hacen pasantías en este hospital, pero también hacen mucho en 3 hospitales que están de más o menos 150.000 habitantes, en Longueuil, Saguenay y Moncton. Y hay 3 hospitales de comunidad para población de más o menos 50.000 habitantes, mucho más pequeño. También en la comunidad, clínicas como lo que hemos llamado Grupo de Medicina Familiar, los GMF, y estos GMF hay en muchas ciudades alrededor en la provincia, y hay 10 community. Pueden ver aquí, es que yo le pointer no funciona, pero pueden ver que hay Sherbrooke, donde es el centro más grande, pero también a Saguenay al norte, Montreal, es Longueuil, que está bien cerca de Montreal, y Moncton. También podemos ver que es en diferentes partes del Quebec, tenemos las comunidades al exterior. En los egresados de la facultad hay más o menos 45 hasta 50% que eligen la medicina familiar como primer opción. Gracias, Charles. También hay más o menos 30% que eligen las especialidades generalistas, y 20 hasta 25% subespecialidades. Hay muchas estudiantes que eligen también de trabajar afuera de las grandes ciudades como Sherbrooke, Quebec y Montreal, o Moncton en Nuevo Brunswick. La mayoría, 65%, trabajan afuera de estas grandes ciudades. Y estamos bien contentos porque el año pasado hemos ganado el premio de la Asociación Canadiense de Rural Medicine, porque fuimos la escuela de medicina que ha tenido el porcentaje el más elevado de estudiantes que trabajan en las regiones rurales, pero que se quedaban en el campo para más de 5 años. El programa de medicina familiar, solamente un poco para la evolución, empezó en 1970 y es un programa de 2 años. Hubo el primer departamento de medicina familiar en 1975 y lentamente ha aumentado los estudiantes y los residentes. Lo que nos ayudó mucho a aumentar los médicos de familia es que fue una obligación de la única vía de practicar la medicina general. Ahora, desde 1988, hay que hacer la residencia de medicina familiar. Antes podíamos hacer un internado, 1 año de rotación y después trabajar en medicina general, pero desde 1988 no podemos. siempre tenemos que hacer la medicina familiar, que hace una preparación mucho más importante, porque se hace no en los hospitales, pero en los medios donde va a trabajar el médico de familia. Entonces, en 2012 tenemos 200 residentes, 60 profesores y también profesores de clínicas, más o menos 500. Los residentes, como lo he dicho, trabajan en unidad de medicina familiar, que están en los grupos de medicina familiar, en cuatro ciudades más grandes y 5 ciudades que están más localizadas afuera de las ciudades.
Before closing the presentation, I think we should talk about nursing education at our school. We have a bachelor degree in nursing since 1979 and a master and PhD program. But since 2005, there are 3 pathways in our nursing program. One is acute care in hospital. Second one is community-based care, which is primary health care. And the other one is chronic diseases and adaptation and rehabilitation. And more recently, we developed a specialized nursing program in primary health care with an extensive collaboration with the Department of Family Medicine. Just to talk about international commitment, we've been involved with the PAO and WHO for many years. We are involved in the Network Towards Unity for Health for more than almost 30 years. Training for Health Equity Net also, and a few others. We have a few international projects which support family medicine department. One in Mali for more than 15 years, which has been well funded. One more recently with Uruguay for the last 6 years, which we are always trying to find more funds, but I think we got some. And we are actually working with Haiti for the last 2 years following the earthquake. And finally, we are acting as a leadership group for the international project for the next 4 years for the Francophone medical schools around the world. There are about 130 Francophone medical schools around the world, and 28 of them have decided to get involved in a long-term project on social accountability. Let's go for the conclusion now. What can we say? What can we say for the conclusion? First, change is not easy. Change is a long term. But change comes from our actions for each of all. And for this reason, I think that for me, I found this citation from Bob Kennedy, and I think it really means what I would like to say about this. The repeated actions of each of all, which means teachers, administrators, health administrators, governments, teachers, even students and population, their acts, how minimal they are and the commitment of all are those elements that make a generational change. The change doesn't come over the night. It comes from a generation. Each of us can contribute and even more be an engine of change, as we said this morning. And if we partner, we will be much stronger. Working together on action, our action will be more potent. And I have a citation which was translated from French, but it says, the piece of rock does not have another initial objective than to be a piece of rock. However, if you put them together, you build a cathedral. The next question is, should we do it? Is it too costly? And then doing it will be costly. It will be costly on our energies, on our resources, on overcoming resistance, and on bringing change. But not doing it will be much more costly. We may think about money, but I think we should think about access, equity, social development, the well-being of our citizens, and I will conclude also about the well-being, more importantly, for our members of our family, our friends, our children, our grandchildren. That change is important for them, for their future well-being, for all these people we love. Thank you.